أتشرف أن أكون بصحبتكم في الإزمة النهاردة في محاضرة خاصة بشركة إكزيديا عن الإيكوزابنت إيثايل which will be launched soon with Exitolab from bench to bedside. Cardiovascular mortality is the leading cause of death worldwide. Every 40 seconds, someone dies from the cardiovascular disease. And every 4 minutes, someone dies from stroke. About 18 million people across the globe died from heart disease in 2015. And over 400 million men and women have a kind of cardiovascular illness. Are triglycerides alone considered a high-risk factor for cardiovascular diseases? Elevated triglycerides alone can lead to death. In an analysis of more than 15,000 patients with established coronary heart disease, screened for enrollment in the bedside infarction study, PIP study, higher fasting triglyceride levels were independently associated with more increase in death after 22 years of follow-up. What is known is elevated triglyceride levels are associated with adverse outcome. However, the independent association between elevated triglycerides and mortality is controversial. What the study adds? In a large cohort of secondary prevention, eligible more than 15,000 cardiac patients followed up for 22 years. Elevated triglyceride levels are associated with an independent risk of death. The association between elevated triglyceride levels and the death is graded in a dose-response manner. Even the triglyceride level from 100 to 149 are associated with an increased risk of death. Are the traditional treatment options enough for protection from cardiovascular diseases? Despite the wide use of statins treatment, their residual risk remains questioned. The residual cardiovascular despite treatment with statins with different types and doses based on the LDL level reduction to reduce the cardiovascular disease is evident in many trials. The use of fenofibrate showed no significant benefit on mortality or cardiovascular protection in patients with type 2 diabetes, which is published in the New England Journal of Medicine about the effects of combination lipid therapy in type 2 diabetes, and this is from ACCORD study group. The ACCORD study group, more than 500 patients with type 2 diabetes who are being treated with an open-label simvastatin to receive either masked fenofibrate or placebo. The primary outcome was the first occurrence of non-fatal MI, non-fatal stroke, or death from cardiovascular causes, and the mean follow-up was about 5 years. What the study adds? The combination of fenofibrate and statin did not reduce the rate of fatal cardiovascular events, whether non-fatal MI or stroke, as compared with statin use alone. So the results don't support the routine use of combination therapy with fenofibrate and statin to reduce cardiovascular risk in the majority of high-risk patients with type 2 diabetes. Omega-3 phase 3 trial on the cardiovascular protection, which called STRENGTH, has been discontinued for not adding any cardiovascular benefit compared to placebo. What is known is that omega-3 has been approved as an adjunct to diet to reduce triglycerides level in patients with severe hypertriglyceridemia with triglycerides more than 500. What the study adds? The STRENGTH was a large-scale cardiovascular outcome trial, evaluating the effect of use of omega-3 4 grams daily compared to placebo on reducing the risk of MACE in patients on optimal statin therapy with mixed dyslipidemia and the high risk of cardiovascular disease. A total of more than 13,000 patients enrolled at 675 sites in 22 countries. The STRENGTH phase 3 trial has been closed. Why? Due to its low likelihood to demonstrate a benefit to patients who are at a high risk of cardiovascular disease. So what is new to do or to add? Icosapent from bench to bedside. What's meant by bench to bedside? This is a term used to describe the process by which the results of research done in the laboratory are directly used to develop new ways to treat the patients. We need 7 capsules of the common omega-3 daily to equalize only 1 capsule of icosapent ethyl. That's why. Because 1 capsule, 1000 milligram of omega-3 contains 30% fish oil, which provide 30% of omega-3 fatty acids equal to 300 milligram, and the AP is only 150 milligram. So we need 7 capsules of regular omega-3 capsules to give 1 gram of the icosapent ethyl. While 1 capsule of icosapent ethyl with 96% APA, this is a highly purified single entity active drug substance with 93% of icosapent ethyl. The icosapent ethyl is the only FDA approved medication that provides 25% cardiovascular protection on top of statin. Icosapent ethyl is an ethyl ester which reduces hepatic, very low density lipoprotein synthesis and or secretion and enhances the triglyceride clearance from circulating very low density lipoprotein particles. Potential mechanisms of action include increased beta oxidation, inhibition of acetyl-CoA, decreased lipogenesis in the liver, and increased plasma lipoprotein lipase activity. The mechanism of action, different levels of mechanism of action. At the level of endothelium, it increases the nitric oxide production. It increases endothelium-dependent vasodilation, and it decreases the reactive oxygen species. It has an anti-inflammatory effect with decrease of pro-inflammatory cytokines and decreased inflammatory cell recruitment. It leads to plaque stability with less plaque formation, progression and rupture, less thrombosis, less platelet activation, and more fibrous cap thickness, which gives stable plaque, less liable for rupture and causing acute coronary syndromes and stemming mortality. The most famous trial in the last 2 years is REDUCE-IT, which showed the effects of icosapent ethyl on total ischemic events. Further insights from the reduction of cardiovascular events with icosapent ethyl intervention trial. The design of REDUCE-IT is they screened about 19,000 patients and randomized about 8,000 patients equally divided into 2 groups, group on placebo and group on icosapent ethyl 4 grams per day, and the median trial follow-up duration was about 4.9 years. The primary endpoint events, cardiovascular death, non-fatal MI or stroke, coronary revascularization, or need for hospitalization for unstable angina, and the key secondary endpoint events was the cardiovascular death, non-fatal MI or non-fatal stroke. The age is 45 years or more with established cardiovascular disease, so this is the secondary prevention cohort, or 50 or more years with diabetes with 1 or more additional risk factors for cardiovascular disease. This is the primary prevention cohort. Fasting triglyceride more than 135 and less than 500, LDL from 40 to 99, and on a stable statin therapy plus minus ezetimibe for at least 4 weeks prior to qualifying measurements for randomization. There is this on primary endpoint, there's a relative risk reduction by about 25% with number needed to treat 21. And this is a key second endpoint, there's a relative risk reduction by 26.5% with NNT by 28. What about specific subgroups for every categories, for every complication, for every value to be evaluated, ending by the total mortality, the use of icosapent ethyl is better than placebo. There is no difference according to the key baseline characteristics between the two groups of icosapent ethyl or placebo, and there's no difference about the medication were used on the baseline before treatment with the icosapent versus placebo. About the incidence of first and subsequent events, for the first event, there is a reduction by about 196. And for the second event, there is a reduction by use by 140. And for the third and fourth, there is a reduction by 71 and 63. So there is a 30% reduction in the total events by using icosapent ethyl. As in common in long-term trials, study drug adherence waned over time, and despite this, there was a strong sustained treatment effect on the total events using the icosapent ethyl. About the total, the first and subsequent events, whether for primary, for cardiovascular death, MI and stroke, need for coronary revascularization, unstable angina, there is a highly significant difference in the group using icosapent ethyl, and also for the total of first and subsequent events for the key secondary issues, there is a very significant difference by using icosapent ethyl. So to compare between the use of icosapent ethyl versus placebo, the endpoint with the primary composite endpoint or key secondary endpoint in favor of use of icosapent ethyl. And the total endpoint events by baseline triglyceride was from 81 up to less than 190 or more than 190 to less than 250 or over 250 up to 1040 and 400. The use of icosapent ethyl is better for each category. So the conclusion compared to placebo, icosapent ethyl for gram per day significantly reduced the total cardiovascular events by about 30%, including 25% reduction in the first cardiovascular event, 32 reduction in the second cardiovascular events, 31 reduction in the third cardiovascular event, and 48 reduction in the fourth or more cardiovascular events. For every 1,000 patients treated with icosapent ethyl for 5 years, there is a reduction by 12% in the incidence of cardiovascular death and 42% in incidence of fatal or non-fatal MI, and 14% for fatal or non-fatal stroke, 76% need for coronary vascularization, 16% for need for hospitalization for unstable angina, and the primary composite endpoint decreased by about 159. What about the evaporate study design? This is to study the effect of icosapent ethyl on progression of coronary atherosclerosis in patients with elevated triglyceride from 200 up to 499 already on statin therapy. The rationale and the design of the evaporate study: two groups of patients, group on APE 4 grams per day and group of placebo, going for up to 18 months. The evaporate study seeks to determine whether the use of EPA by dose of 4 grams per day will result in a greater change from the baseline in blood volume than placebo in statin-treated patients using the IRBUS as a maneuver to calculate. The evaporate shows that 46% mean plaque regression with exidolab. Evaporate is an imaging study in statin-treated patient with coronary atherosclerosis with level of triglyceride 200 up to 499 and the LDL 40 to 115, randomized by 1 to 1 for icosapent ethyl for gram per day or placebo, with primary endpoint the change in low attenuation plaque volume after 9 months, and secondary endpoint the incident plaque rates, quantitative changes in different plaque types and morphologies. At 9 months, EPE slowed progression by 21% for low attenuation plaque, 19% for total non-calcified plaque, 42% for total plaque, 57% for fibrous plaque, and 89% for calcified plaque. In marine trial, which shows that icosapent ethyl 4 gram per day hits 65% reduction in triglycerides on top of statin. And this is a very important issue, that EPE 4 gram plus statin can reduce by 65%. Even the use of EPE 2 gram plus statin show a reduction by 40%. What about the guidelines recommendation? The icosapent ethyl is the first option in hypertriglyceridemia on top of statin. In high-risk patient with triglyceride ranging from 135 to 499, despite statin treatment, the use of icosapent ethyl 2 by 2 grams per day should be considered in combination with statin, and this is class 2E level of evidence P. Icosapent ethyl indication, first FDA approval in 2012, and recent cardiovascular risk reduction indication in 2019. Severe hypertriglyceridemia indicated as adjunct to diet and to reduce high triglyceride levels in patients with more than 500 milligrams per deciliter. For cardiovascular risk reduction, indicated as an adjunct to maximally tolerated statin therapy to reduce the risk of myocardial infarction, stroke, coronary revascularization, and the need and unstable angina requiring hospitalization in adults with elevated triglyceride more than 150, and established cardiovascular disease or diabetes mellitus, and 2 or more of additional risk factors for cardiovascular disease. And thank you very much for attention and ready for any question. Thank you very much.